Olá, pessoal. Boa tarde. Espero que vocês já estejam animados aí à tarde, voltando do almoço. Muito obrigado por estarem todos aqui. Muito obrigado mais uma vez aos patrocinadores e aos organizadores do evento. Obrigado especial ao nosso querido amigo Bruno Furquinha, Dental Press, e ao nosso amigo Laurindo também, por estar junto aqui, né? Estarmos todos juntos aqui nessa tentativa de angariar o máximo de fundos possível aí para a gente conseguir ajudar esses nossos colegas que estão, como vocês viram, essas são imagens que cortam o coração, porque a gente se vê na situação, fica se imaginando o que seria de mim se eu tivesse nessa condição agora. E tem pessoas que estão nessa condição. Então, pessoal, dá um print screen aqui, ó, nesse nosso logo aqui em cima, nesse nosso QR Code aqui, ó, e por favor, pessoal, por favor, uma doação pequena pode ajudar a juntar outras doações aí para a gente poder auxiliar um pouco que seja a esses nossos colegas saírem da situação. Pessoal, voltamos agora aqui à tarde. O nosso primeiro compromisso aqui à tarde é com o professor Padhraig Fleming. O Padhraig Fleming aceitou gentilmente se unir a nós aqui nessa corrente do bem, nessa corrente para tentar ajudar várias pessoas, e gentilmente cedeu seu tempo para estar aqui hoje. Primeiro contato que eu tive com ele, ele falou na hora: vamos, Kleber, vamos fazer isso aí, eu topo, eu quero ajudar, tá? E o Padhraig está aqui conosco, eu vou falar um pouco sobre ele. Padhraig é chair, ele chair da Universidade Trinity, que a maioria aqui fala português, em Dublin, former professor. Ele foi professor da faculdade e consultor do treino de pós-graduação em ortodontia da Universidade Queen Mary, em Londres. Ele foi premiado com distinção em 2007, membro da British Orthodontic Society, medalha de excelência em 2008, PhD em 2013. Ele é um editor associado do American Journal of Orthodontics and Dental Facial Orthopedics, British Dental Journal, Journal of Dentistry e Progress in Orthodontics. Um dos editores do board de inúmeros outros jornais, né? Faz parte do board de inúmeros outros jornais. Ele publicou mais de 190 artigos em revistas peer-reviewed e numerosos artigos publicados de pesquisa. Ele foi também premiado com o prêmio Turpin, da American Academy of Orthodontists. Ele é um dos únicos ortodontistas que foi premiado por the Helen E. Dewell Award from AAO também, né? Em 3 ocasiões. Quer dizer, ele foi o único que foi premiado em 3 ocasiões, isso que eu quero dizer. Orthodontic Textbook Clinical Cases in Orthodontics. Ele também é coautor da Functional Appliances Theory and Practice, Fixed Orthodontic Appliance, a Practical Guide, em 2023, do Graeber, né? Graeber Orthodontics. Current Principles and Techniques. Espero que também trabalha em clínica privada, tá? em período parcial. Então, um currículo vasto e com uma grande produção científica e também com casos clínicos fantásticos que ele vai mostrar agora. Padhraig, muito obrigado por se unir a nós. Thank you very much for joining us, my friend.
My pleasure.
It's a great honor for us here in Brazil to have you join us in our this meeting. It's very important for people from this part of Brazil. You know, the problem they are facing now, it's very difficult for them, and you are helping us on this to join us to help them to have a better, at least a little bit of a relief in their difficult time. Thank you very much for being with us.
Thank you, Kleber. Not at all. Thank you, Kleber, and I really do appreciate the invitation as well. And obviously, I'm delighted to help in any small way for what obviously has been a terrible tragedy. Hopefully, guys, you can see my screen there. Is that okay? Yeah, great. Okay, so thank you again for asking me to speak this evening. I was asked to speak about the twin block. So I'm going to hopefully give a very clinical presentation on the use of the twin block appliance. A little bit of background, first of all, about me. So as Kleber said, I am now based in Dublin. I'm Irish. I graduated from Trinity College here in Dublin back in 2002. I spent 17 years in London, and I returned actually to Dublin about 18 months ago to take a chair here in orthodontics. It's a lovely university right in the centre of the city. If any of you do visit Ireland, please do get in touch and say hello to me. As Kleber mentioned, I have written a number of books, spent quite a bit of time writing. I was very honoured to be asked to contribute to this textbook on the right-hand side here, Graeber 7th edition. And you probably don't know this, but on the cover is actually my daughter. That's my daughter, Sophie. She had braces on at the time, Kleber, when I took that picture. And I've told her that if she's really good with her retainers, she might be on the cover of the 8th edition as well. So obviously she's got a fixed retainer, as you might imagine, as well as removable retainers. But fingers crossed those teeth stay nice and straight. So we're going to go through the twin block. I'm going to introduce my own approach in terms of design, in terms of treatment pathway. I'm going to look at some specific presentations. We've only got 30 minutes, so there's only so much I can cover, but hopefully some useful tips within this. The first thing to say, I suppose, is that the twin block is certainly not the only functional appliance that I use. I see lots and lots of different alternatives in terms of class 2 correction based on presentation, even in children and adolescents as well. Lots of information on this particular slide, obviously very welcome to take a picture of it, but there are certain scenarios in which I would certainly not use a twin block, including patients with increased vertical dimension, long face syndrome, etc. I just don't think it's an appropriate appliance for them, for example. But we're going to focus on when we do use a twin block. And for me, the ideal time to use a twin block is in the late mixed or early permanent dentition. Ideally, when the first premolars have erupted, in a patient with a large overjet, 7 millimeters or more, with favorable vertical dimensions. So normally average or slightly reduced vertical proportions. So that's the ideal patient. And I'm actually going to start by showing you treatment of an ideal patient, just to give you a basic outline of how I tend to do it. So this is a young male patient with a very large overjet, 13 millimeters, class 2 molar relationships bilaterally, deep bite, and a large overjet, about 13 millimeter overjet. Mild lower arch crowding and an upper median diastema. Facially, skeletal 2, mildly, fairly average vertical proportions. There's a soft tissue component here as well with a lip trap. And he's got, as I said, that increased overjet of 12 to 13 millimeters. So I would consider this to be the perfect candidate for a twin block. He's in the permanent dentition, mild skeletal 2 pattern, average or reduced vertical dimension. So how do we design the appliance? Well, I think the key is to keep it simple. So in terms of retention, first of all, I tend to crib, first premolars, first permanent molars as well. That's it, okay? I've also got some retention on the lower incisors, but that essentially is all that is required. In terms of clasping in the lower arch, well, some people would suggest maybe don't crib the lower first permanent molars. Maybe that might affect our ability to reduce the overbite if we crib the first molars. Actually, it doesn't have an effect. The overbite reduces very, very rapidly with the twin block, even if you do crib the first molars. And the reason I do crib the first molars actually is because cribs tend to fracture. So if you look at research studies, about 2 in 3 patients have one crib fracture. And I tend to think if I've got 2 cribs in a quadrant, if one of those fractures, it's just not a problem. I can simply just snip the crib off and the patient can continue to wear their appliance, and we don't need to take the appliance off them or do any major repairs. It's just easy. So it's kind of managing that potential risk of breakage. That's what we go for 2 in the lower quads as well. In terms of anterior retention, what do? Well, I just simply put ball-ended clasps on the lower incisors. Generally these days, I'll put 3 ball-ended clasps on the lower incisors. Now, some people will tell you, Padhraig, if you put just ball-ended clasps on the lower incisors with a twin block, your lower incisors are going to procline. And I will say, yes, you're right. Your lower incisors are going to procline if you just use ball-ended clasps on the lower incisors. But I would argue no matter what you do to the lower incisors when you're using a twin block, they will procline somewhat. The only exceptions are if you put TADs in the lower anterior region, or maybe if you use a lower labial bow when you've got a spaced dental arch. That's about the only time we will not get lower incisal proclination. This study here, for example, they compared use of a labial bow versus ball-ended clasps, and they found no difference. Lower incisors procline no matter what you do. Lower incisors have got low anchorage value. They've got short roots. You pit the whole force of the upper dentition against them, they're going to procline no matter how you clasp those incisors with a twin block. Now, in terms of bite registration, how do we manage that? Well, first of all, if you want to do some further reading around the twin block, Bill Clark's papers are excellent. Send me a message after this lecture and I'll forward that paper on to you. But Clark's recommendations are very straightforward. He normally suggests 2 to 4 millimeters of opening anteriorly and blocks that are 5 to 6 millimeters tall in the first premolar region. So let's look at this patient. How would we take the functional bite in this patient? So you may remember he had unit 2 molar relationships bilaterally. He had that large overjet. What am I going to do? Well, in terms of my forward posture, when I take my functional bite, I will essentially take that bite simply in an edge-to-edge position. Because we know that we can normally translate the mandible comfortably by about 1 centimeter to 12 millimeters in that open position. So that would be perfect for a patient that's got an overjet of around 12 millimeters. So we'll go for maximal advancement, ideally to an edge-to-edge incisor relationship. In terms of the vertical opening, as Clark suggested, 2 to 4 millimeters of opening anteriorly and blocks that are 5 to 6 millimeters tall in the first premolar region. Why that height in the premolar region? Well, essentially, it is a trade-off between the appliance being comfortable and ensuring that the patient is actually posturing forward. If the blocks are too tall, it's really uncomfortable. If the blocks are too short, they'll just be biting block on block. They will not be in that forward postured position, which we require for our class 2 correction. So 5 to 6 millimeter tall blocks in the first premolar region. So very, very simple again. So what about recall intervals? How often do we see these patients? Well, generally what I've done historically is to see a patient after a month just to make sure they're getting on okay and to add in whatever extra ingredients we've suggested, like expansion, like maybe a sectional fixed appliance or whatever we're combining with our twin block. And we then just see them at 3 monthly intervals. So it's a very, very simple appliance to manage and to supervise. So why do we start expansion after a month? Well, as I'll talk about later, compliance with a twin block can be difficult. And I tend to think if a patient is asked to turn a screw, a midline screw in a removable appliance, particularly a twin block, over the first week or two, as they're getting used to the appliance, it can be difficult. They can forget to do it. They may not be wearing the appliance enough. And suddenly the fit of the appliance itself becomes a problem. Equally, we do want to expand early because we know expansion takes time to occur. And what we don't want to happen is that we just start our expansion too late in treatment and therefore have to prolong our twin block phase for the expansion to occur. So we start that expansion early, but not at the start. So 1 month is a really good time to start, I find. So this is this patient after 5 months of treatment. So you may remember large overjet, deep overbite, 5 months in, maybe posturing very, very slightly, but he certainly seems to have got pretty good correction. So I've got lucky here. He's grown, he's worn the appliance very well, certainly got pretty good class 2 correction. He's overcorrected in the molar region, overcorrected in the incisor region. From the face perspective, again, he's skeletal 1, maybe mildly skeletal 3, but again, perhaps a slight postural here. But he's at pretty rapid class 2 correction. So that brings me back to that forward posture. So I advanced his mandible in one go, took that edge-to-edge bite. Was that the right thing to do? Some people historically have suggested, for example, with Frankels, certain types of functional appliances, that maybe we should go for stepwise or incremental advancement of the mandible. Might that result in greater condylar change and skeletal change? Well, if you look at the research, the answer is no. It doesn't make a difference. So you can simply, safely go for one-step activation, and it will not affect the nature of change that you get. You will get the same amount of skeletal change if you advance in one step. And from a patient management perspective, that's simple. So that's the way that we do it. Now, you may have noticed that this patient, again 5 months into treatment, has a very, very big lateral open bite. Is that a problem, and why does it happen? Well, it happens first of all because we've got acrylic covering the occlusal surfaces of the teeth. They no longer erupt to the posterior region, and therefore, as the incisors erupt, we end up with lateral open bites. And that is a problem, certainly Bill Clark would suggest, in terms of occlusal stability and in terms of condylar support. But in reality, that's for a very, very short period of time. And also, hopefully, this patient is wearing their twin block most of the time. So they're getting condylar support from actually biting, into the occlusal blocks anyway. So I don't actually personally think it's a problem. And therefore, when it comes to ways to close these lateral open bites, we've got some flexibility. We can do one of three things. We can either trim the appliance during treatment itself, or we can correct the lateral open bites after the block, either by tapering or reducing the wear, or completely withdrawing the appliance altogether. And actually, what I tend to do is just to completely withdraw the appliance for 6 weeks after I finish my twin block treatment. So my patients wear their twin blocks generally for 12 months. They stop completely for 6 weeks to allow the lateral open bites to close, and then we proceed on to fixed appliances if that's what our plans are. Now, on the other hand, you can trim your twin blocks. You can trim the upper component, you can remove your cribs, you can allow for some settling to occur during the functional phase. That's another way of doing it, and that's what Clark, for example, suggests. Okay, but I feel it is not absolutely necessary. Now, going back to this patient, we're 5 months into treatment. As we said, he's got significant class 2 correction. He's got his overbite fully reduced. In him, actually, I did trim the blocks. So I've trimmed the upper block really positively here. I've actually left the lower crib in place, and we then just leave it with a 4 months or so. What happens? Well, if you look at the images here between 8 and 12 months, you can see that the lateral open bites start to close, not fully, but they close quite significantly over that 4-month period. You might also notice that the overjet has relapsed slightly as well. So maybe he was posturing a little bit after 5 months, or maybe he's just not wearing the appliance quite so well over the last few months of twin block treatment. And that is common. So I use my twin block for 12 months. Why is that? Well, it's because we've done quite a bit of research on this, and one of our feelings initially was that maybe if we use a twin block for a little bit longer, maybe you might get more skeletal change. And maybe that might be better, obviously, from a facial perspective, and maybe even from a stability-based perspective. But actually, I think the real reason wearing the appliance for 12 months is helpful is because we do not get as much occlusal relapse after twin block therapy. If I go back to when I was training to be an orthodontist, I tend to use my twin block maybe for 6 months. I got really rapid class 2 correction, and then I put my fixed appliances on, and what happened? I had lots of occlusal relapse. Class 2 correction recurred. So instead, we now use the appliance for about 12 months. We let the change, hopefully solidify, and therefore we're getting really nice, stable occlusal correction. And on that basis, if we're using the twin block for 12 months, I know growth is going to happen around the appliance. And I don't tend to think that if you use, for example, a labial bow or a different piece of metalwork, it will affect the amount of growth that you get during your treatment. And that's because no matter what happens, I am generally using the twin block for 12 months, unless I'm extracting teeth as part of my treatment. And that's not that common when I'm using a twin block. So in my practice, therefore, it is a 12-month course of treatment. Unless it's an obvious distraction case, I'm doing this because it gives us better stability at the occlusal level and allows me just to completely withdraw the appliance after 12 months and then just let the patient, wear no appliance for a period of 4 to 6 weeks to allow those lateral open bites to close. It simplifies the transition. So therefore, when I move into fixed appliances, I'm not going to need, I think, use of early class 2 elastics or headgear or anything like that. It is much, much simpler. So how do we then transition into fixed appliances? Well, very simply, we just reevaluate the case, we reset our objectives. So we'll take a KEF, we'll get some digital models, we'll set our objectives again, and we'll reset our treatment plan. Very, very straightforward. And in this particular case, well, yes, we've got some lower arch crowding. We will certainly have had a little bit of proclination of the lower incisors during the functional phase. Maybe there's a small space requirement associated with that, but it is minor. And then we will plan our treatment carefully. And we will always set not just inter-arch objectives, but intra-arch objectives as well as inter-arch. So we'll have objectives for the lower arch in terms of maintaining lower incisor position to allow me to easily close that space in the upper arch. We'll plan a little bit of interproximal reduction in the lower arch in this case. We'll manage mesial tip expression in our lower canines to prevent lower incisor advancement, and we'll transition onto fixed appliances very easily. So we did a 12-month period of functional appliance therapy here. We progressed onto fixed appliances, very, very simply, just working through the arch wires, and a very, very straightforward course of fixed appliance-based treatment generally, after that functional phase. Minor points here, but if you look at this image just on the upper right, got a slight class 2 canine relationship on the left side, 3 months into the fixed phase. Would I run class 2 elastics at that point? I don't need to, and I definitely won't, because I've got quite narrow upper incisors. I've had an upper median diastema. If I run my class 2s, I risk the lower incisors coming forward and complicating that space closure in the upper arch. Fundamentally, because we've got really nice class 2 correction anyway during the functional phase, we just didn't need, to use class 2 elastics during the fixed phase. So a very, very simple course of treatment, fixed appliance phase, maybe over around about 11 months or so, and a very, very straightforward, correction of that malocclusion. So that was a simple case, very, very straightforward. And that shows us most of the mechanics that we will use during our twin block phase. What about, however, a patient with proclined lower incisors? Any adjustments that we might make in a patient like this? Well, if we look at this example here, this is a patient with spacing in the lower anterior region. Okay, and people tell me, well, Padhraig, if you've got proclined lower incisors prior to a functional appliance, maybe I shouldn't use the function because the function might procline the lower incisors further. Well, actually, I tend to think if you're using a functional appliance, really what it is an efficient form of camouflage in a growing patient. So yes, our objective between start of treatment and end of treatment will be to avoid proclination of the lower incisors. But if a mild skeletal 2 discrepancy remains at the end of my treatment, that is probably to be expected because we know functional appliances do not grow mandibles long term. So I'm not concerned about the proclined incisors in the lower arch, but what I am concerned about is space in the lower arch. Because space that remains in the lower arch at the end of the functional treatment makes fixed appliance-based treatment post-functional more complicated. And I'll try to explain why. So this patient had, again, quite a significant skeletal 2 discrepancy. So quite a difficult case to manage. However, overjet was not that large because we had that spaced lower arch. So I would suggest we need to correct that spaced lower arch during the functional phase, not just during the later fixed phase. Why is that? Well, if we don't, we're going to have a compromise at the end of the functional phase. If you imagine you've got class 2 relationships, increased overjet, pre-functional, the ideal situation, I would say, is that even post-functional, not just post-fixed, post-functional, we've got class 1 relationships everywhere. So why is that of concern? Well, if you haven't corrected the lower arch length at the end of your functional phase, there has to be a compromise somewhere that you're going to have to deal with in terms of your anchorage management during the fixed phase. So I would say there's two possible scenarios if you don't correct that long lower arch. The first is that the molars are class 1, but because you've got a long lower arch, your lower incisors are too far forward. So you got a class 3 incisor relationship. You might think, okay, that's fine. That's kind of, overcorrection. But actually, how would we correct that during the fixed phase? You might have to run some class 3 elastics. If you do that, well, it becomes a little bit less predictable. You might begin to lose, for example, upper molar anchorage, or have to do things to preserve your upper molar anchorage, which are often not that predictable and less simple for patients. So I prefer not to be in that situation. The other scenario is that the incisors are class 1, but because you got a long lower arch, your lower molars are too far back. Again, you say, well, we can correct that pretty easily. You can. Class 2 corrector, but the problem is, again, your patient is going to be more mechanics, and they've already had 12 months of twin block therapy, so they might be a little bit tired and a little bit less compliant. So I would prefer if we didn't have to do that. So what do? We simply manage that lower arch length during the functional phase, either with a sectional fixed appliance or maybe just with a simple lower labial bow. And that way, we'll hopefully end up with class 1 relationships throughout before we move on to our fixed phase. So again, we look at this patient. We had that lower arch spacing. What do? Well, we decided we need to reduce that lower arch length during the functional phase. So I've got a lower labial bow. Okay, we activate it. We let it run for a few months, and what happens? 3 months into treatment, I've closed some of the space, but actually I have a lower midline shift now. Maybe I've closed a little bit more space on the right side, perhaps, but actually I've probably not quite got my functional bite right. So how do we manage this? Well, very simply, we can reactivate our appliance, create some micromechanical retention in our component, maybe use triad gel or TKO, for example. I tend to then sculpt the twin block against the upper, put some Vaseline on it, and just reactivate the appliance. The other way of doing it, I find these days, is just using Compomer. Here I'm just using some Transbond Plus. So I just place that into the upper component of the twin block, mold the lower component against it with some Vaseline on the lower component, and again, off we go and move forward in terms of class correction. So we reactivate it chair side. It takes about 3 minutes to do, and we can again proceed with our treatment. So if we look at this patient then 10 months in, we've managed the lower spacing reasonably well. You can see hopefully most of that is closed at this point, and we can then move on to our fixed phase. We've got no anchorage management issues to sort out, and it becomes a really, really simple, phase of treatment to undertake. So even I can do this with fixed appliances pretty easily. We get this done over a period of about 10 months, something like that. So really straightforward with the treatment. Now, what about retroclined upper incisors? Can we use a twin block, for example, in a patient with class 2 division 2 incisors? We certainly can. Really, really simple. And we don't need to overcomplicate this. So I would say in a patient like this, 2 div 2, a twin block works quite nicely. And what we tend to do is to combine our upper fixed appliance, a sectional fixed appliance, with the twin block and carry out our fixed appliances and our twin block concurrently. So this was a 14-year-old male, 2 div 2. He's got asymmetric molar relationships. So class 2 subdivision, class 2 on the right side, class 1 almost on the left. Deep bite and some crowding. And again, a significant skeletal 2 pattern. So what do? Well, we simply place an upper fixed appliance here from upper canine to canine, align the upper teeth, and I introduce that sectional fixed appliance during the twin block treatment. So in terms of phasing, what I will do here is I will actually take my functional bite in a class 3 relationship. So I'll posture the patient forward into class 3 because we know we can posture them forward 10 to 12 millimeters very, very comfortably. It doesn't matter if they're in a class 3 incisor relationship. I'll then add my sectional fixed appliance about a month into treatment. We'll start to decompensate the upper incisors. We'll get some distal tipping, obviously, of the upper posterior teeth, and we need to be careful and recognize that as we move on to our fixed appliances, because as mesial tip expresses itself, we will have an associated anchorage implication. So we move into fixed appliances and hopefully detail the outcome. So that's the phasing. Functional appliance first, add our sectional fixed appliance after a month, functional for 12 months, and move on to complete fixed appliances. And a very, very straightforward, again, class 2 correction. Now, finally, guys, just in terms of compliance. So one elephant in the room when it comes to the twin block is the fact that it is a removable functional appliance. And this is a big disadvantage. And people will tell you, well, a twin block is really well tolerated. It's a predictable appliance that patients get on with. And its growth has been quite organic, certainly in the UK and Ireland and, Australia, etc. It's popular, but there's nobody marketing it. But we have to be honest, failure rates are quite high, particularly amongst patients who are not paying for their treatment, as high as maybe 30%. So that's a problem. So we thought, well, maybe if we suggest maybe a less onerous wear regime for patients, they might actually comply a little bit better. So how about suggesting wearing the twin block just 12 hours a day? So what we did was to undertake a clinical trial where we randomized patients to either wear the twin block for 12 hours a day versus full-time prescription 22 hours a day. What did we find? Well, what we did first of all was we incorporated this microsensor within the appliance so we could objectively work out how much our patients actually wearing their twin block. What happened? Well, actually, there was no difference in terms of the ability to reduce the overjet, whether we're using our twin block full-time or part-time. There was also no difference in terms of the skeletal effect of the appliance either. And these were patients with really big overjet. So on average, the overjet reduction in this study was 7 millimeters per patient. Yet, even with part-time wear of the appliance, we were able to reduce these overjets pretty much fully. Now, patients, I'm afraid, you probably know this already, are kind of lazy. We ask them to wear their appliance for 12 hours a day. What happens? They're actually wearing them for 8 hours a day. We ask them to wear them for 22 hours a day. How much are they wearing them? 12 hours a day. So half as much as we asked them to. So they are a little bit lazy. But the key point is, despite that, it is enough. Part-time wear seems to be enough to correct the occlusion. So we sat down, we asked these patients lots of things about what makes them wear the appliance, what makes them maybe a little bit more reluctant to do it. Okay, we learned quite a lot about their habits on this basis. And this research, I would say, is changing my practice. I think the biggest problem about getting patients to wear a removable functional appliance is school. So I don't want my patients at the start in particular, certainly for the first month, wearing their twin block during school. So I ask them to wear the appliance at weekends, evenings, in bed at night, but not during school time for the first month. I'll try and fit the appliance during holidays, Easter, summer, half terms, etc. I do think that contact at the start is important because we learned that the first month really quite challenging. And this is why I never fit sectional fixed appliances. I never start expansion either for the first month because that's when it's hardest for the person. So I try to make their life easier at the start. And in terms of recall, what I try to do now because of research is to keep in touch with patients. So we've got remote monitoring, we can contact patients remotely, we can do video calls as necessary to stay in touch over the first month or so to encourage them to make sure they're wearing their appliance. And again, as I said, we don't start expansion or fitting fixed appliances until 1 month into treatment as well. So in terms of wear prescription, I know now that compliance is limited, they're not wearing their appliances full time, but part-time wear is sufficient. I definitely will therefore taper the introduction. So I'll tell them to wear it in school or not in school at the start, but at home in the evenings, in bed at night and at weekends. And I will not tell them to wear the appliance during eating either. And some orthodontists still do, but I just don't think it's required. In terms of design, you know this already, but I don't use a labial bow very often. Vertical opening is important. keep it at 5 to 6 millimeters in the premolar region, 2 to 4 millimeters anteriorly. And as a rule of thumb, a patient should look better with the appliance in place. And you look at this patient, unfortunately, on the right side of my screen, they're not looking better with that appliance in place. They are not going to wear it, I think, and they won't do that well with it either. We can try to remind them as well in certain ways. I do think that is helpful. So guys, that essentially is the twin block. My simple messages are to keep the design really simple, minimize the wire work, and be flexible with a part-time introduction of the appliance. So that was the twin block, guys, in 30 minutes. I would have liked more time, but I hope that is some introduction, Clever. And again, thank you guys very much for the invitation. My thoughts are very much with you there. And I do hope that you guys recover as quickly as possible from what has been a terrible tragedy. And thank you again.
Okay, my friend Padhraig, very good presentation. We also would like to have you for like the whole weekend.
I only needed another 20 minutes, and I could have told you about the twin block, but I did my best. So I hope it was useful.
No, it was very good. You know, it had lots of clinical tips. And, you know, when I asked you to do this type of presentation with the twin block, I was thinking about myself, I must say, because I love this. I love your cases. And I have never worked with the twin block before, but I was thinking about it. Every time I post something on like mandibular advancement, people keep asking, why don't you use the twin block like Dr. Padhraig? I will do that next time.
I'd like to do things like you, Clever. So
come on. So thank you very much for being with us today. It was a very good, great presentation. We really loved, and all the support you're giving to us in this terrible situation now. It's very important for us. We are going to keep it in our minds. Thank you very much for that, my friend.
Thank you, Clever, and hope you have a lovely day. Take care, guys.
You too, my friend. Bye-bye. Take care.